Hello, everyone, friends and colleagues. Thank you so much for the kind invitation for this, for inviting me to speak at this prestigious conference. And really, today I've been given the topic to talk about the dilated left ventricle. And one of the therapies from the percutaneous options that we have out there in terms of treating the left ventricle, despite the GDMT that we know from the current literature and guidelines. And I've been privileged to actually be involved with the AccuCinch, total restoration system, which is the core cinch heart failure pivotal study, which is ongoing right now in the US and Europe, and really telling you what the data has provided us in the last 1 year and 2 years, and take you through the physiology and what exactly do we do from this percutaneous option in terms of the dilated left ventricle. So here are my disclosures. And as you see that despite the treatment advances of GDMP, we know that the residual risk in terms of the heart failure with reduced ejection fraction still remains very high. So we know the 4-pillar GDMP MT from the ANCHOR reduced trial. We know the addition of SGLT2 has really revolutionized how we treat these patients on top of the other medical medications that these patients are on. And it really has impacted in terms of mortality and heart failure hospitalization in these group of patients who are NYHA class 2 population. And not only that, in terms of heart failure reduced ejection fraction, we also know in patients who have heart failure reduced ejection fraction and posterior in the COAP group that they too do really well despite on GDMT, that percutaneous option with percutaneous mitral intervention of the anterior with the mitral clip, in addition to GDMT, has shown additional benefit in terms of mortality and heart failure hospitalization in the COAP trial. And so, what is important in this besides GDMT and percutaneous option? The goal of heart failure therapies is for reversion modeling. So there's a lot of papers out there in terms from imaging standpoint. What really stands out from reversion modeling? We look at the left ventricle volume. It stands out among all the surrogate markers that strongly correlate with the impact of particular drug or device therapy on patient survival and mortality, as you can see on the diagram on the right-hand side in terms of reduced left ventricular end volume, and so in terms of increasing stroke volume and increasing in left ventricular ejection fraction. And so how does the accuracy work? So it really uniquely as a percutaneous option treats the dilated left ventricle. So you can see on the left-hand side, it's placed with anchors right below the mitral annulus, and it is to treat dilated left ventricle. And the mechanism is really in terms of reducing the size of the ventricle, reducing the LV wall stress, and so it does initiate what we call biological reversion modeling, and with the goal of endpoints in terms of improving the quality of life, their functional capacity, their heart failure hospitalization rate, and certainly with life expectancy. So here's an example of video of the catheter and the wires of the procedures of the AccuCinch you can see going underneath the mitral valve annulus, and this is guided by both fluoroscopy and echocardiography guidance. Putting the anchors right below in terms of in the muscles of the left ventricle, and you can see again, repeat video again, in terms of placing right underneath the mitral annulus, and your placement of the anchors, and you can see cinching of the left ventricle in terms of reducing the left ventricular size. And really is an impact that certainly has shown in our current data. And so this, you can see here, the procedure time that we have shown within 1 year during the early days is only 131 minutes in the paper that was published in Jack Cardiac Heart Failure. And so on the left-hand side, before you cinch it, you can see the anchors, and on the right-hand side, post-cinching, the reduction in the left ventricular size that you can actually detect on fluoroscopy as well. And so it is a very controlled deployment. Been in a couple of cases of this in terms of the anchors and the spacers along a flexible cinch line. And so certainly echocardiography during procedure is important. You want to make sure that you're not interacting with the subvalvular apparatus using a lot of transgastric use, and also your mid-esophageal use in terms of placement and the catheters positioning as well. And so here on fluoroscopy, once you have all the anchors placed underneath the mitral valve, you see immediate post-procedure LV reduction on the left-hand side on fluoroscopy, where you get about 8.7 centimeters, 8.7 millimeters. And here on the right-hand side, you can see on cardiac CT, 12 months post-procedure in terms of the CT modeling. And you can see on the pink color that was the baseline, and after 12 months post-procedure, immediate you have reduction of your LV volumes and improvement of your LV function. And so here I'm going to present current data that we have on accuracy transcatheter left ventricular restoration in heart failure reduced ejection fraction. This is our early experience, and we have followed up these patients, or 51 patients, with a 2-year outcome. The article we have is on 1 year, but certainly in terms of the 2-year outcome is what we want to see, whether the sustained reverse remodeling is sustained until 2 years. So just a recap of the baseline characteristics of these 51 patients. These patients are relatively young at 56. The majority of them are male, with component of it being a ischemic component. They do have the common cardiovascular risk factors and previous bypass and PCI. They do have, in terms of besides their medical management, they do have cardiac rhythm management devices in terms of ICD or CRT. It's not a contraindication. The majority of these patients are also in NYHA classification class 2 or 3. Now, in terms of the echocardiography baseline from a transthoracic standpoint, you can see on the right-hand side, the left ventricular ejection fraction is about 30%. In terms of mitral regurgitation, we do screen out severe mitral regurgitation, so you can see a lot of them have moderate or less mitral regurgitation, and certainly in terms of the left ventricle, from a linear dimensions and also in terms of volumetric measurements, certainly you see that these ventricles are dilated, they have large left ventricles and diastolic and also systolic volume as well. And so in terms of procedural results, immediately you see a lot of these patients, the procedure time is 131 minutes. We usually put about 13 anchors, and all of these go pre-procedural screening with CT to make sure that the left ventricle wall thickness are adequate enough. It's not too thick because you do not want to pierce them, so certainly that's a screen failure. And in terms of LV reduction, we get about 9 millimeters, similar to what in the early days, about 8 to 9 millimeters. And in terms of safety outcomes through 2 years, safety say that these devices are actually safe. You don't have any death, stroke, possibly related, but certainly in terms of myocardial infarction, we don't have it. Excuse me, and in terms of the other cardiovascular risk factors, certainly this device has proven to be a safe and certainly effective in the next couple of slides data that I'm going to show you. So here you can see in terms of improvement in left ventricular and diastolic volume and ejection fraction through 2 years, that we see an improvement of at least 30 mils. And this small amount of improvement in diastolic volume actually reflects in the improvement in left ventricular ejection fraction. Even by 5%, you have an increase in LV stroke volume, and these patients actually do better, and that's their physiological remodeling that they get. You have increase in forward stroke volume. And so, in terms of the left ventricular and diastolic volume, you can see the transition, excuse me, throughout 2 years. Throughout 2 years that you can see the left ventricular and diastolic volume really has improved all the way. I'm so sorry. Has really improved all the way, not only to 1 year that was reported, but also all the way up to 2 years. And here in terms of the remodeling, so once we have the procedure done, we anticipate that acute left ventricular reduction will initiate what we call a physical left ventricle remodeling, and after about 6 months or so, despite the LV being the same, it induces in what we call a biological reverse remodeling. So that reverse remodeling in terms of a physical and biological reverse remodeling continues to take place, not only up to 1 year, but all the way up to 2 years. So certainly in terms of this device, percutaneous device, certainly is very promising all the way up to 2 years. So we certainly are seeing that, and we will continue to see that all the way up to 5 to 10 years.
In terms of left ventricular ejection fraction, as I mentioned, you have 5% increase. Even that small amount, you see that physiological remodeling, that forward stroke volume, and that is translated into your quality of life. And that is in your KCCQ score all the way up to 2 years, that you still, these patients do well. They feel better despite being on GDMT. You have that reverse remodeling, and certainly is a therapy that is really promising. In terms of NYHA, all the way up to 2 years, you can see the improvement in terms of class by more than 50%. If it's improved, at least by 98% as well, all the way up to 2 years. And 6-minute walk test concurrently as well, you can see certainly, and more or less at 12 months, you see a steady at 3 months, 6 months, and 12 months, but certainly in terms of the other quality of life, certainly has improved. Now, we do not collect at 2 years as per protocol, but in terms of the other quality of life measures, certainly shows a real good promise. In terms of time to all-cause death, 90% survive at 2 years. In terms of the remaining 5 patients, they unfortunately they pass away at more than 280 days, as you can see on the right-hand side. There were 3 patients who had LVADs at day 13, 395 and 589 days, and 0 heart transplant. So certainly in terms of time, to the all-cause death, certainly it has helped for this group of really sick patients. In terms of the events post-procedure, you can see certainly it has certainly helped in terms of heart failure hospitalization and total amount of events in terms of death, in terms of LVAD, heart transplant, and heart failure hospitalization, as you can see on the table on the left. And so overall, the accuracy certainly established itself very durable, long-term safety and sustained improvement. So certainly it's on the left-hand side, it's favorable in terms of the survival and improvement in heart failure hospitalization, improvement in quality of life and function capacity, as you see in terms of KCCQ score by 19 points, similar to other medical devices in the structural world. New York Heart Classification, you see the improvement in that, and certainly in 6-minute walk test too. But most importantly, all of these in terms of KCCQ score and survival really goes down to the LV reverse remodeling. Once you see the improvement in the left ventricle and the function, I think that physiological changes is translated to all benefits that we see in this group of patients. The number may be small, but certainly in terms of the pivotal trial, that's what we are looking at, and we look forward to the data once they have finished in terms of the enrollment. And so in terms of who and when do we consider these patients when we screen in our heart failure clinics and together with my heart failure colleagues. It can be ischemic or non-ischemic, reduced ejection fraction from 20 to 40%, dilated left ventricle, anything more in terms of the transthoracic echo left ventricular end diastolic diameter of more or equals to 55 millimeters. Not significant mitral regurgitation for this trial at the moment, but certainly something that we can think about in the future. But for specifically for the pivotal trial, no significant mitral regurgitation, because we do not want to mix in terms of the cohort of patients and keep it excluded. These patients go rigorous screening with our heart failure colleagues during the screening calls in terms of making sure that they are on maximal tolerated GDMT with the 4 pillars, including the presence of whether there's device management in terms of ICD, CRT, and or even percutaneous mitral options of mitral tear. And most importantly, they do have to be symptomatic with either recent heart failure hospitalization, NYHA classification class 2, 3, or 4 with a 6-minute walk test of at least 100 to 450 meters. So really all these heart failure patients that we see in clinic, we screen them really rigorously with our research team and giving them an option. Is this, what we consider upstream therapy? Should we do this, before consideration of the percutaneous circulatory support, an LVAD? So those are the things that we're trying to expand the options of these patients with heart failure reduced ejection fraction by a percutaneous option and delaying all the other options of LVAD and, hospice care. So certainly this is a therapy that is promising. Looking forward to the results of the pivotal trial that's currently still enrolling, and certainly hoping to finish, and then we see the outcomes of these patients. And so the key points in terms when we treat the left ventricle, I think is understanding the left ventricular remodeling in heart failure therapy. Certainly echo is the first go-to, is my first love, obviously, but certainly combining it with advanced cardiac imaging like CT and cardiac MRI is what we do during the trial too. And also in your clinical practice, just to ensure if the imaging from the echo is not optimal, thinking of advanced imaging modalities. And like I said, the role of percutaneous option in heart failure as an upstream method. Could we do this before thinking if a patient has LVAD, in addition to GDMT? So these are the things that if the results of this are promising, obviously certainly will be guideline related. And so really we are creating new clinical pathways for this group of patients besides GDMT and the advanced heart failure therapies. And so there we are in percutaneous options besides the M-tier. And this all will translate to more new clinical pathways and insight and impact on survival and quality of life. With that, thank you very much.